During my internal medicine clerkship, I had the privilege of rotating with an academic hospitalist team in the third largest hospital system in Florida, wherein we noticed the length of stay average was much higher, 8 days, as opposed to that of the national average, 5.5 days. So what could we do to ameliorate this problem? In self-reflection, we realized our academic team had to consult patients on different floors with different protocols. How could we reinforce standardization of care while maximizing efficiency of our team? Perhaps if we had a single assigned hospital unit with consistent staff and procedures, this aspiration would be a reality. In working with administration, an academic hospitalist team, composed of 2 hospitalist providers with medical students and residents, was allocated a single hospital unit, complete with nursing staff, social work, and other ancillary staff. The single unit would be the sole geographical location of our patient list. In this observational study, a total of 508 patients were enrolled. Patients that were excluded in the study were patients that left against medical advice. Patients that were included were provided by an independent admitting team. Data was collected by secondary data analysts who did not participate in patient care. So the 3 outcomes you see on the left-sided column were measured each month for 4 months prior to implementation of the initiative, as well as 4 months after implementation of a single assigned hospital unit. Measured outcomes included length of stay, LOS, patient satisfaction, PS, and number of discharges. Length of stay was measured per patient and was subsequently averaged between different patients in a given month. The mean LOS was calculated from the averages between months. Patient satisfaction was assessed via National Standard Survey, known as the Hospital Consumer Assessment of Healthcare Providers and Systems, and was completed upon completion of care. The survey is a 6-question survey which had a goal of 5 out of the 6 questions having 100% satisfaction. This means that the total satisfaction indicated by the survey was desired to be 83% or higher. The data was analyzed via descriptive analysis with calculations of percentages, means, standard deviations, as well as confidence intervals. Please note the following results in the middle column of the poster. Please note that orange indicates before implementation of the initiative and blue indicates data collected after. Please look at the total number of discharges, as well as the mean discharges with the confidence interval, the patient satisfaction before and after implementation, as well as the length of stay, mean and standard deviations before and after implementation. So, total number of discharges increased by 30%, and the confidence intervals before and after are essentially not overlapping. Patient satisfaction remains the same, yet above the predetermined goal of 83%. While length of stay did not significantly change, consistency of length of stay was higher. This can be seen as the post-implementation standard deviation is 1/10 of the pre-implementation standard deviation for length of stay. In analyzing this data, it is imperative to go ahead and look at the case mix index, the indication of which is indicated on the right-hand column. This equation measures the cost of resources needed to treat our mix of patients. It reveals how sick our patients are. The higher the CMI, the more complex the patients, and essentially it indicates that the resources we've utilized are costly and or complex. The bottom line is that this CMI index significantly reflects hospital reimbursement. So returning to the equation, if number of discharges are increasing by 30%, then CMI index increases by 30% proportionally. Some limitations of the study include the lack of diagnostic related group data. Without this data, we cannot fully complete the CMI equation, and thus we cannot make a certain conclusion. We also do not have readmission data. How many of our patients that we discharged are actually coming back? Furthermore, there are admission differences between months that can be plausible. The prospective nature of the study includes finishing this current pilot study with the year of implementation. In addition, we would like to include more FIU-based PAs and nurses to improve the consistency of patient care within that of their respective schools. We would also like to integrate FIU's Neighborhood Help program, which helps improve continuity of care, particularly in communities with a low SES status. This will assist us in our lack of readmission data, as well as improve patient outcomes. Thank you very much for listening,